So as this is building up, obviously the sequence of all these different topics are building into a continuum of a story. We talked about sequencing technologies, the technology behind that, interpreting that, the data, and then now just obviously with the ecosystem and privacy, and all of this builds into the final topic today, which is on treatment of rare diseases. Now that you've identified this, what do you do with that? And so with that, we have the panelists up here. And it'll be PJ Brooks who will be moderating, but we will kick it off with Alexion, followed by Pfizer, and then the roundtable.
So I'll start with introducing myself. My name is Joanne Burkout. I'm a senior principal computational geneticist working with the Pfizer Rare Disease Research Unit. And so in the spirit of introduction, I do mostly work in the preclinical, really across the spectrum as a geneticist, from identification of targets to understanding of mechanism, all the way through to natural history, and really taking that towards not just data, but the patient and their presentation and their experience. So it's really been a pleasure to be invited to join you and to give a brief introduction to this session, which I think is going to prove really exciting. I'm just going to share a couple of slides, which is on treat genetic disease and a place for newborn screening, just to keep it in context of this conference today. So I think as pharmaceutical companies, and really as a lot of the people in this room, whichever perspective you come in from, we really do approach rare disease as genetic disease. And that's really the grounding for the work that we do and the work that many of these people do. A couple of statistics on the right that I think many of them should be familiar to you. Despite being a rare disease, they are collectively very common. 1 in 10 Americans, about 30 million people in the US total, will be affected with some form of a rare or genetic disease throughout their lifetime. There are between 7,000 and 10,000 different distinct rare diseases that have been described to date. Certainly that number is expected to increase and may have a little flexibility. The curators in the room may think about lumpers and splitters as we understand the genetics better. 80% of these have a well-defined genetic origin. And that gives us really a lot of information. And that allows us as researchers to understand the basic biology of the disease, to draw those gene-disease relationships, to understand what's going on and build some biology understanding around those. It informs the translational researchers, which includes pharma and industry companies, about how you might want to treat the disease. Not all diseases are loss of function. Sometimes there's repeat expansions, there's gain of function, there's poison peptides, there's a whole lot going on. And really genetics is a key piece of that puzzle to get us towards understanding what you need to change and how you could change it to be impactful and translational and effective as you design a therapy to treat these diseases. We've entered the era now where the gene itself could be a medicine, whether that is a gene therapy. AAV is a really common one right now. CRISPR and gene editing, rather than simply being the target of your drug, could the gene be the drug? And that's a really exciting space to be in as well. I think it's really important as you continue down the pipeline, we're no longer talking exclusively about the research system and the research ecosystem. Taking this genetic information, this clinical genetic information, has reached a point where having that in hand is a key piece of the puzzle for clinicians in order to understand the expected trajectory for their patient, in order to identify the most appropriate therapeutics, including some novel and bespoke therapeutics that may be available for a gene-specified rare disease. Certainly we do not want to, underplay this at all, despite them being last on the page, is that the patients really need this information. They need this information to get that accurate diagnosis. They need that as key information for their management journey. And it's been unfortunate, but the average time to an accurate diagnosis of a rare disease is years at this point. It remains 6 to 8 years, according to this resource that I've pulled. And many of these patients are pediatric, so they're on a clock, and they really have a family who is putting in a huge amount of effort and a huge amount of burden to the family to really understand what's going on, where genetics can really help accelerate that process in a meaningful way. And so in the context of newborn screening, I think this is just a wonderful opportunity to bring genetic medicine to the patients directly. We've been working in the field for a very long time with genetics data as a research resource, and it is becoming more of a clinical resource as we move forward, which is very exciting. So newborn screening allows early detection of risks, allows that dramatic shortening of the diagnostic odyssey, allows confirmation and validation of concerning conditions before the advanced pathology is developed, and it allows us even that window of opportunity to look for therapeutics and interventions that may prevent the most serious adverse consequences from occurring in these patients to begin with. And I've put up on the screen 3 images of 3 different patients who've shared their stories with the internet. First, we see Anna, who has PKU. And, some of you may remember, those of you who are older in the audience, that used to be, a diagnosis that would lead to very severe, burdensome mental health, developmental delay because of that accumulation and damage to the metabolic system that accumulated in the brain. And with, at this point, biochemical screening, PKU can be identified, or PKU risk can be identified, diet can be managed, and this patient, Anna, did not experience that, and that's a wonderful thing. Indy, who is age 7, is living with maple syrup urine disease, another very rare disease, very difficult to diagnose early on, but they were able to catch this, again, from a very early screening. I believe that was a biomedical screening, and she has also been able to escape developmental delay as a consequence of her disease, because they were able to give her an effective therapeutic in a timely way. The last patient, Malachi, who is alive and mobile with us, SMA1. And so SMA1, it used to be a death sentence, and now there's a gene therapy available. And really that's where we're headed. We're going to be able to take this genetic diagnosis into really transformational impact for patients. And I think that's what brings most of us in the room to our work every day. But of course, we are not going to live in this idealistic world. The grand challenge is, of all the data that's available in a genome or in a gene panel, which variants really should be treated as medically significant, and medically significant in a way that is actionable or treatable or developable. So newborn screening really holds a lot of special challenges in this space. The patients themselves, as has been discussed several times and really introduced nicely by multiple of the other speakers and panelists, the patients may be pre-symptomatic. The findings may be incidental. They may be a carrier of a variant with an uncertain penetrance or a limited penetrance. And that variant detection is not yet diagnosis of a disease before that patient has presented any symptoms. And so understanding that relationship is really an important part of not just having genetic medicine, but having newborn screening in a genetic medicine context. The occurrence of symptoms, observation or validation or with a robust or even pathognomonic biomarker is really an excellent and essential part, in my mind, of the needs that we have right now. The idea to say, not only do you have this genetic variant, but we can really confirm that risk of presenting disease in this patient in a way that we would like to make actionable. Again, the variants themselves, we've heard a lot of information this morning on the interpretation of variants. I do think that this is really where one of the big bottlenecks is, and where we want to pay a lot of attention, spend a lot of time, including as people who want to be very translational and impactful in the future. Understanding that interpretability as the key bottleneck in this space, both for returning results to patients, which ones do you tell them about, which ones do you hold back, because it can be very confusing if you are not yourself a geneticist. And as we've heard, which I think we all understand, statistics are difficult. So really determining the treatment eligibility of a carrier, when and which one. So there's a lot of functional assays that can be developed and brought to bear to this problem. Bespoke guidelines for which gene interpretation guidelines you may wish to incorporate to be more explicit and robust in the interpretation of a novel variant, and really investing in the medical genetics and genomics workforce, I think are some really essential points of where we are. And with that, I just want to close. I'm not here to give you all the answers because I don't know them yet myself, but I think this is it just as an industry researcher, as a clinical geneticist, or not a preclinical geneticist, I think we're in a really exciting part of the research space right now, and taking that towards this translational impact is something that's really very important to us, and I look forward to discussing.
So first of all, it's really great to see you all in person. A number of you I've worked together with for 3 years and have not seen. So it's been really, really nice to see everybody together again. Next, this session's around improving the treatments for rare disease, and in this case, by shortening the diagnostic odyssey for rare disease patients. And I wear two hats. My first hat is as the Deputy Head of Diagnostic Strategy and Development at Alexion Pharmaceuticals. And we're really concerned about the question of making a vision of the world where every patient gets the right treatment at the right time. And what we've talked about recently is a big step towards doing that. The second hat I wear, of course, is as part of Beginnings. So Alexion is one of the founding members of the Beginnings pilot and consortium. And we're really looking to end the diagnostic odyssey. And that really fits with the vision of what we're trying to do at Alexion as well. And I'm the deputy chair of that consortium, working with Stephen, and really proud of the work that we've done so far, and really excited about the work that we're doing, planning for the future. I'm gonna skip this because we just basically talked about it. What's impressive is the scope of the plan. Now, this is a bit of an audacious goal, right? But it is an important one, and it's what we're talking about. We'll talk about that more tomorrow, is that for starters, we're looking at, we've completed a feasibility prototype this year. It's been published a couple weeks ago, should certainly take a look. And for the rest of this year, we're starting a clinical trial to understand how can this work in one hospital, the Rady Children's Hospital for starters. And then we'll be expanding to multiple hospitals next year, including Greece, I think I see Petros up there, and including Tennessee. And we're going to be working to expand in measured ways, but expanding rapidly. The key here, though, is that in a relatively short period of time, we may be talking about a very large number of newborns who are being sequenced and screened and ultimately diagnosed. And that's going to have an impact and really be changing the treatment of these children. And that's what I want to talk here about for just a few minutes. So the first thing to understand is we're not looking at every disorder. We're looking at treatable disorders, right? So here are some of the inclusion criteria for beginning right now. Is the natural history of the genetic disease well understood? Does this disease have a significant risk for morbidity and mortality in infants or young children? Is this a serious disorder? Is the treatment or intervention available that is effective and accepted? This is really key. We're not looking at all the diseases, we're looking at ones that we have treatments for. And does that treatment improve outcomes? And do the benefits of early intervention clearly outweigh the risks? And for genes with more than one associated disorder, do the treatments differ, and can you distinguish them? So these are a number of pretty weighty levels, but we still have 380 diseases that have fit that criteria so far, and we look to continue to expand them. So in this paper, and again, the reference is on the bottom, one of the key things that Dr. Kingsmore did was do a comparison for the known diagnosed kids that they've seen at Rady, and look at how those kids would be diagnosed by newborn screening by a whole genome sequence with Beginnings, but also compare that to how they were diagnosed before in the NICU and the PICU. Now, these kids in the NICU and PICU, you've heard about his successes there. It's tremendous, right? Incredibly rapid diagnosis that's been very effective at helping the lives of these kids. But we're also now looking at newborn screening, and this brings into a new situation where these kids are being diagnosed in basically 2 weeks. How would that diagnosis in 2 weeks change the quality of the care? It turns out it changes it quite a bit. So 65% of the time, these kids have, in this retrospective analysis, these kids have either a significant or complete predicted reduction of symptoms. That's a really big deal from a patient point of view. It's also a big deal from the future of these treatments and how they move forward. So here's a small subset. These are the diseases that were thought to be the patients who were thought to have a condition where their phenotypes could be completely eliminated if you treated them earlier. things like hereditary fructisuria. And the type of phenotypes we're talking about are real: vomiting, encephalitis, hepatitis, seizures, intracranial hemorrhage, cardiac arrest, arrhythmia, respiratory failure, malignant hyperthermia, Schwachman-Diamond syndrome. These are symptomology that could be avoided if you do newborn screening. So from a point of view of treating these kids, by going earlier, you're having a major impact. And that's something I think everyone in the room should know. And that impact has a lot of follow-up effects. First, obviously you have the impact on the kids that you're looking at right now. But we'll find that existing therapies are going to be more effective because the kids are getting them when they need them. They're getting them early enough to have a maximum impact. You'll also find that therapies will be approved for earlier treatment. Once this resource exists, then companies will go back and say, can we potentially get approved for earlier treatment? Because we can see that improvement in outcomes. So you'll see more and more of these medicines being approved for earlier treatments. And also more future therapies will be developed. Now, in the way that's been designed so far, a disease is only on the list if there's a therapy available. But a lot of the gene-targeted therapies, for instance, really need a diagnosis very early. I've talked to about a dozen CEOs of small biotech companies, and these CEOs recognize that in order for their companies to be actually viable, they need a solution like this to exist, because they need to be able to find their patients. And so having this actually come to pass will have a massive impact on patients' outcomes, because more and more therapies will be developed if they know that they can reach these infants in time to have a positive effect. And so that particularly has an impact on rare and ultra rare diseases. So if you're looking at, so let's say, in 6+ years, this is a future state. We're hopeful we can accomplish this, right? You're looking in 6+ years, and you have an incidence of 1 in 100,000. That's a pretty rare disease, right? But if you're talking about 3 million newborns in the United States, you're talking about 30 per year. That's starting to become a significant number. And if you just look at worldwide, let's say you get 10 times as many, you're talking about 300. This is a population that is reasonable to create medicines for. You're looking at 1 in 300,000. You're talking about still potentially 100 worldwide. If we can make this work, and this is why it's so important for us all to work together on this and find a solution, it'll be transformative in my mind to how these kids are treated and how the practice of medicine continues. And just some acknowledgments from the last paper we wrote. A lot of folks from Rady have been doing some amazing work. A lot of folks from Alexion that I'm really proud to have worked with, and of course, some folks from Genomenon. There's a broader set of people who are involved. I picked the acknowledgement section from the last paper that was given, but I think that folks in this room, a lot of people are looking at this newborn screening by whole genome sequencing problem, and we have the opportunity to really have a big impact. Thanks.
Thanks, Tom. So my name is PJ Brooks, not PJ Brooks Scott up there, just PJ Brooks from NCATS. I'm the moderator of this session, but Robert said I could make some comments, and I feel like this would be the time to do it after the two presentations. And I think the point I want to make is that we often think about newborn sequencing and potentially leading to development of treatments for disease, and we often think about individual treatments for individual diseases. But we're living in a world now where what we have are therapeutic platforms that are broadly applicable for the treatment of monogenic disease. AAV is certainly one, gene therapy, lentiviral vector gene therapy. Oligonucleotides are another. You've all heard, I'm sure, the story of Melis and how Tim Yu went from a single gene mutation to a treatment for one little girl in less than a year. And that's because there's a therapeutic platform he built on that was used for the treatment of spinal muscular atrophy. And the other one that really stands out is genome editing, and particularly I'm struck by development of technologies from David Liu's lab, where they've taken the Cas9 system and attached to it DNA repair enzymes, so they can create what are called base editors that can correct single base mutations. And the first one they made corrects C to T mutations, which is, of course, the most common single base mutation that causes human disease, almost 45% of all single base mutations. So now, when we have these therapeutic platforms, if you identify a patient whose symptoms are caused by a C to T mutation, regardless of the disease, you in principle have a therapeutic for that individual. And that, I think, changes the existence of these gene-targeted therapies as therapeutic platforms. Really, I think, changes the whole calculus of what we consider to be an effective treatment for a disease. It's almost like the paradigm doesn't fit, a round peg in a square hole, whatever. And I think this was the impetus for a series of meetings that we had at NIH over a year ago. Many people here participated in them. And by we, of course, I want to acknowledge my colleague Tina Irv, who's here, who led that effort, along with Melissa Parisi from NICHD, who maybe is listening online, and myself. And we had this series of meetings to kind of address this question and the implications of this for newborn sequencing, newborn screening, and many more broader societal implications of the question. I just thought I wanted to bring that up because I do think it will come up later on in the meeting, and perhaps we'll follow it up here, but just wanted to put that out there. So after that, let me transfer it over to my other panelist, Melissa Wasserstein.
Thank you. Hi, everybody. I'm Melissa Wasserstein. I am from the Children's Hospital at Montefiore and Albert Einstein College of Medicine in the Bronx. I'm a medical biochemical geneticist, so I manage and diagnose children with rare inborn errors of metabolism, some PKU, MSUD, hereditary fructose intolerance. And I'm also the principal investigator of Screen Plus, which is one of the pilot programs that we'll be discussing tomorrow.
Wendy?
Hi, I'm Wendy Chung. I'm a medical geneticist based at Columbia University, and among other things, lead the Guardian program that I'll be talking about tomorrow, and also work on development of therapies for rare genetic diseases.
And Adam.
Good afternoon. My name is Adam Kennedy. I'm the Associate Director of Research and Development at Metabolon. A little bit orthogonal to what a lot of people have been discussing here today. We look at small molecules, so looking more along the lines of the impact of what those mutations do on the metabolome of a patient. And so examining those small molecules, not only in the context of biomarkers of disease, but how those patients then respond to treatments as well. So doing a lot of genome-wide association studies and seeing if the sort of the biomarker panels that are currently in use could be expanded to identify more diseases for newborn screening, hopefully in the future, and these rare diseases.
Great. Thank you all for that introduction. So I guess I'd start off with sort of one question. Maybe I'll go to Melissa. We're talking about treatments, and we can also think about, I guess, treatability. And maybe you could talk about how your work with, adaptation of newborn screening gets to that question of treatability.
That's a wide open question, and I think I sat in the hot seat here. But so treatability is an interesting question because I think that we all go into the concept of newborn screening with kind of eye in the sky, thinking, yes, everything's treatable. We need to pick them up early so that we can treat and manage everything. But the reality is that there are some disorders that we're not quite sure yet what they're going to look like. I think that for many disorders on newborn screening panels, I use the word pre-symptomatic. We have children that might have an abnormal biochemical phenotype, but might not have symptoms yet. They might have variants that we think might be pathogenic, but they might not have anything yet that we would need to treat. So defining what treatability is in the context of early detection is something that we're learning about in the context of pilot screens. And I think that somebody had mentioned before the importance of doing longitudinal follow-up. How do we know that what we're screening for is treatable and requires treatment, and that there is actually a benefit to this early detection?
Thanks. Does anybody want to follow up on Melissa's comments? Or
I'm going to push the envelope a little bit further. So when we were planning Guardian, we actually started about 3 years ago, and we started by asking that question to parents, to ask them what they would want and what was treatable and what was acceptable for their definition. And the interesting thing is that many of you know that I also work in areas of neurodevelopmental disorders. And so when I think about that, I also think about opportunities for early identification of, for instance, epilepsy and treatments of epilepsy and early intervention in terms of behavioral and or educational or therapeutic opportunities in that way. So not necessarily the gene editing at that point, but we also think about windows of opportunity in terms of childhood development. And interestingly enough, the parents actually said, yes, I'd want to know that. If you can tell me, for sure, my child is going to have these issues, they're going to happen in the first few years of life, I want to know that so I can help them be the best version of themselves. And in fact, I'll talk about it tomorrow, but as we started rolling that out, of the parents who have been offered that option, the vast majority say that, yes, that's treatable enough. That meets my definition of what I'd want for treatability.
I would add that the most important thing that we're focusing on is the value of what we're doing here is so high. We want to make sure that we're able to be successful and get these solutions out into the real world. And so I think it's important to really focus on the conditions that are really agreed on as being treatable as much as we can so that we can move these solutions forward. I think there's a lot of great opportunities for a number of different areas, but for starters, let's look at the ones that are severe, are clearly agreed to be treatable, so we can sort of move this forward successfully and be a little cautious in that way, because the overall effort is so ambitious and the value is so high.
I want to add one thing about the concept of treatability, and I'm putting on my newborn screening hat, just from routine newborn screening, where we have been screening children for 50 plus disorders in New York State, and we define them all as treatable. But what does it mean if you take a child, for example, with an organic acidemia, and you put them on diet right from the get-go? It's treatable, right? But you transform this otherwise fatal disorder into kind of a prolonged, often disabled person. Is that treatable or not? And I think there's a lot to think about when we say treatable. It's not a yes or no. There's a lot of nuances in there.
Yeah, I think that's fair. I guess, Tom, to your question, I'm thinking also about, I guess I'm thinking back to Mila. Would we have thought about that as a treatable disorder? When the genetic variant is so obviously clearly tied to a disease and you could develop a therapeutic intervention, would we think about that as treatable?
At this stage, I would say not yet, until you've shown that it's effective. So like if you've shown that that intervention is effective, then yes, it's treatable. But I think that the physicians do need to agree that, broadly speaking, that intervention represents a treatable intervention.
Okay, some good comments. Joanne, can you tell us a little bit more about the stuff that Pfizer's doing with newborn screening in Europe?
So a little bit, but that's really the work of my colleague Nicola, who's there in the front row, and we'll be telling you a lot more about it tomorrow. I believe they're on session, I can't remember what time, but hopefully you'll be there all day. But there is an initiative that we're putting together. It is a multi-industry academic partnered consortium to really start looking at developing a panel and developing an actionability plan, how to return these results, and work with European researchers and clinicians, including Alessandra, who's in the front row, to initiate a genetic newborn screening plan and partner with Illumina, and I believe we've seen an Illumina person here, collect those data, try to interpret and understand them and see what we can do to impact the patient population there. So again, I I hope I did it at least a little bit of justice, but you'll hear more and better tomorrow.
Okay, thank you. Adam, I want to go to you and see if you could talk a little bit more about how the approach that you're taking at Metabolon could ultimately lead to potential of identifying treatments or treatable diseases.
Yeah. So what we're hoping, and I think we're in the initial phases of successfully doing, is doing something like Tom said, is identifying some of those newer targets that that could be identify what some of these treatable diseases are. So we've in the courses of something that was said in, I believe, in the not the last panel but the panel before, some of these mutations and the diseases are very context dependent. And so we've in looking at families that have multiple mutations or multiple affected siblings, what is the penetrance of those different mutations? Can there be targets made to specific transporters for those different diseases? How much is diet dependent upon this? So we've looked at different reference populations when it comes to different populations around the world, whether it's Middle East, where there's obviously very high consanguinity, also Europe, Southeast Asia, and things like that, and then seeing if those therapeutic interventions can be teased out by looking at the biochemical mutations associated, or the biochemical biomarkers with those associated mutations, but then in the context of what else is going on within those reference populations.
Great, thanks. So I know we're certainly going to want to open the discussion up to people in the room. So if people want to raise their hands while we're continuing on here, we'll be happy to call on you. Wendy, I know that I know from various family groups that you have a lot of interaction with a lot of very, very rare disease patients, and they're coming to you and trying to get your advice on what they can do in terms of going forward in various types of therapies. And I wonder if you could kind of talk about some of the way you think through the different options.
Yeah, that's a lot. A lot of folks do come to me, and I'd say it's changed over the years in a good way. I'll just say one of the things that I find that I think is probably true is that as patients are getting diagnosed younger, which is really important, families have a different sort of way of thinking about this, and I will say they almost bifurcate in terms of those who become very activated, is the way I describe it, but they're really searching very hard, literally from around the world, any resources they can to get to. Regardless of financial resources, in many ways will bring what they have to bear. That is friends, family, connections in terms of being able to find their journey forward. Other folks, I would say, are genetic nihilists, and they just, with that diagnosis and with information, they come to peace with it, but decide that that's not something aggressively they want to do. And I'm okay with that. I mean, in terms of until we have something that's really transformatively curative for those conditions in terms of the journey that they decide. The thing that I guess I have a saying that some people know me for, which is the care until the cure. And the sense that I'm trying to give folks is that we have to use everything that we currently have available so that they will be ready for the day that comes, which I think I agree with you are going to be these platforms, which I describe as a step function, right? And so and I think there are a couple dimensions to that. So some is the technology or the delivery system itself. So whether it's an ASO, vector-based system, prime editing, whatever it is, and that's one dimension. Another dimension ends up being the part of the body, and depending on different parts of the body, I think are easier or more difficult to get into. And when it's the entire body, it's yet even more challenging to do that. And then the third element is time, and when you get in that disease process, and if you've hit a point of irreversibility or a point that you're really not going to be able to get as much bang for the buck as you'd like. And so as we're doing it, we talk a lot about this idea of the being able to maintain and have the strongest sort of best functioning body and person ready for this, for whenever that's available. And then for those to be able to think about what are truly going to be difficult decisions in terms of cost and benefit, if they want to be one of those brave pioneers to be first in terms of some of these technologies. And it's interesting to watch families as they go through the calculus and thinking about that. You've mentioned Mila a couple times. She and her family have certainly been brave pioneers in terms of thinking about that, and have inspired many, many other families in terms of being able to think about that. And I won't go into the details, but as you said, ASO technologies are some of the most flexible and adaptable in terms of being able to develop those N of 1 treatments very quickly. And so, and Lorem, as an example, is devoted very much in terms of being able to do that in the same way that Tim did for Mila, but now being able to do it for many, many other children and patients, especially with neurodegenerative conditions. And time will tell if that's successful and how successful and generalizable that is. But takes a lot of effort just to say, even for one, a lot of effort just to make that one child or one person better.
Yeah, I guess that's the problem and the potential opportunity, which is if these things were developed as therapeutic platforms right from the start, that would, I think, change the way that patients interact with the system. I think the system now doesn't work that way. We think about developing one treatment for one disease, and it seems unfortunate to me when you have things that are so obviously therapeutic platforms. And I think, it would be valuable if we could change the way we do that. I'll throw in one little plug here that one of the funding opportunities we have now through the NIH Somatic Cell Genome Editing Program is to support clinical trials of genome editors where they have to use the same editor and the same delivery system, but do more than one disease. So they have to do it as a platform. And we're trying to see what the regulatory path will look like and try to normalize the idea of developing these as therapeutic platforms.
So I'll jump in for a moment and speak expansively on behalf of the system.
Go ahead.
And I think when it comes to what a lot of people have been saying so far is that we want to focus on treatable conditions. And then what you've been saying about this platform is we really do want to bring that together. And there's such an amazing toolbox right now that almost any condition, given sufficient effort behind it, maybe excluding certain aneuploidies or malformations, has the potential to be treatable. I think we really are in a very exciting space. And what we need from, again, the pharma industry and developer perspective is really we need to improve our understanding of the epidemiology, of the patient experience, of really what are the needs and how can we bring what are somewhat limited resources to the right places to really start working on the problems that remain unsolved and the conditions that remain conceptually but not practically treatable.
Yeah, I just wanted to clarify one thing, which is when I talk about treatable conditions, it's fantastic that we're working to develop the validation of these systems. And as soon as you have it, if we get newborn screening by whole genome sequencing to work, then we have a way to access those patients, right? So I think it will catalyze all of that work as well, but we do need to make sure that we demonstrate that these treatments work.
Yeah, and I think what we're talking about in many of these approaches, like Mila and like one of the ones I mentioned, is we're still doing clinical trials to see if these platforms will work the way we think they will work. And I do think in terms of, because I don't want to be raising false hopes here, we can say that in principle, some of these therapies could treat many, many genetic diseases, but also we have to realize, as Wendy pointed out, right now we're a long way from that. There's parts of the body we can't access, we can't deliver to effectively. And you also have to think about the progression of disease and a neurologic abnormality that happens in utero and changes the way the brain develops. We're not going to be able to treat that. So I think there's practical limitations, and I do think it's important to say that. So I think we have a question up here.
Hi, is this one? Okay. So I'm Jessica Douglas. I'm a genetic counselor at Boston Children's Hospital, and I'm curious as to the panel's perspective on the intersection of treatability and age of onset. If we have more and more treatable conditions, and we're learning over time perhaps that treating them pre-symptomatically, if we know that they exist and will manifest, how are we going to define what early age of onset or young childhood means, and how big of a criteria should that be in newborn genomic sequencing?
Anybody want to try that one?
I can give a few thoughts. I think one of even though idealistically that really we would love to be able to treat patients before they present disease, I think treating them purely on the basis of having a variant is still a little bit of a black box, because there is a lot of complexity that goes into a variant presenting into a disease state, and we don't want to be premature and expose a child or a person to overtreatment, to potential risks associated with particularly advanced interventions, even if they would be beneficial. And so I think really working with early biomarkers where you can get it very early, but where the disease has begun to declare itself, at least a little bit, for many of the conditions we're talking about. Of course, there are some conditions that the variant is less probabilistic and is more definitive, where, if you have sickle cell mutation, you will have sickle cell disease. If you have, a deletion in the DMD gene, you will have Duchenne muscular dystrophy. There's some that we know very well, but I think as a space, there's just a lot of ambiguity that we need to work through at this point still.
So I think that's a great question. I think one of the problems with ultra rare disorders, like many of those that we're talking about, are that we've mentioned before natural history, which we just really don't. It's always one of the criteria on Wilson and Youngner, we don't understand the natural history. When we started screening for PKU, we didn't even know there was something like hyperphi, which encompasses a lot of the referrals that we get. We just didn't know it. We didn't understand it. We learned it as we started screening. Now, it would be lovely if we understood the natural history of a symptomatic patient so that we can compare what happens and when we should intervene with somebody that we diagnose pre-symptomatically. Is that still natural history? If we diagnose them through newborn screening and then follow it and intervene, is that still natural? Probably not. It's an intervened history. But what's really important is that we collect that history going forward. And there's been many attempts across the board to collect registry data. What's happening? How do we follow these children? One state alone is never going to be enough. How do we actually all work together as a newborn screening community to gather that data and continue to follow it, not just for one grant funding period, but continually, which is the length of time that you would need to follow it to see what the intervention looks like?
Yeah, I agree 100%. And I think that it's perhaps half the value of this is being able to capture that natural history data on these different variants that we see can potentially provide us the confidence on when and how to intervene. I think it's terrifically important.
So I'll just absolutely endorse what everyone else has said. I've been impressed at how much I've ended up using the UK Biobank data as an example, which is not really what we're talking about. We're talking about truly prospective from the newborns, but even just to be able to use that as a lookup and to be able to see certain variants. And if you live to be an adult, and if you ended up joining the UK Biobank, was that phenotype what you predicted it to be? I can tell you innumerable times I realized that certain things were not as bad as I thought they were once I was able to see them and see the associated phenotypes.
Okay, thanks.
Yeah, and I was just going to say, echo what was just said. In the biobank studies we've done, looking at those, as what Dr. Wasserstein said, was looking at those longitudinal analyses is what's been so important in identifying those, making sure what's actionable versus what's just an early noisy change in the data. So yeah, definitely following those longitudinal changes to get that learned history is the way to go.
Question over here.
Tom Westover. I may be the only obstetrician in the room surrounded by pediatricians, but I'm also sit on the newborn screening advisory committee for my State Department of Health, so I'm used to being surrounded by pediatricians, or being outvoted maybe. So I wanted to ask a question about the whole concept of treatability versus manageability versus non-treatability. And I've been impressed by sitting on my state newborn committee that the focus has been to focus on the current patient in front of you, the current child, as opposed to future pregnancies or future children. And there's a body of literature that says that up to a quarter or a third of recessive Mendelian disorders are not diagnosed in a family until the second child. So I wonder about this focus on using treatability if the apex user is the family and then the couple, and if focusing on the family health going forward, if really treatability or interventionability, so to speak, should be the focus, and maybe we should not be focusing on that, because families are just as concerned about non-treatable conditions as they are about treatable conditions. Or inclusivity on NGS panels.
I love what you said. I think that we are still living in the dark ages where treatability is a definition. We can only screen for disorders that are treatable when there are so many other potential benefits through early detection, including exactly what you're talking about, planning for that individual's future, planning for the family's reproductive future, avoiding the diagnostic odyssey. You can run a whole list of what those might be, but right now we're still using treatability. So I think it's time for the newborn community to really rethink what the benefits are for early detection, and that can open up a whole wide array of things we might be screening for.
We're actually in our state convening a committee to reevaluate the vision of our newborn screening process. So that is one of the things we think about, and how to link obstetrical screening, which is its own paradigm, to pediatrics.
I'll just say that this evolves within an ecosystem of a life course, though, right? And so what I would argue, and I work with a lot of obstetricians, is that, and we do it some, is that we should be doing that preconception carrier screening, at least for those conditions that are recessive conditions, so that for the families that want to make those family planning decisions, it's based on 0 rather than based on 1 affected child. So that's the first point. The second is that we can always do better and better diagnostic testing for symptomatic individuals and do it faster. And so I think that's within the ecosystem of all of these things that we should be improving in terms of genomic medicine. And if this becomes a public health issue, I don't think the public health newborn screening program has to bear the burden of all of the worlds. I think there are multiple ways to accomplish the goals that you want to.
Question up there.
Hi, Charlotte Hobbs from Rady Children's. I'm a neonatal hospitalist and genetic epidemiologist, so I spend a lot of time in the newborn nursery, working with parents and NICUs as well. So in NICU setting, right, you ask parents when you have a 23-week-old, what do you want us to do? So I'm really interested, Dr. Weiserstein, in your comment earlier, which was really important information for me to hear from you in terms about effective treatment. So when we look at the Wilson and Younger criteria, of which there are several, if you question about, as you are, about whether or not we have the effective treatment, are there other criteria that you would prioritize that would make you say, yes, let's put this on a newborn sequencing panel or not? And the same with Dr. Chung as well. Same question.
I said that because I want to just define, we're in a therapeutic session, so, and I don't want people to think that you need drugs or a diet to treat, because I do think I would definitely include early intervention and physical therapy and all of those things as treatment for sure. But I do think that it's important to bear in mind when people hear the word treatment, especially lay people, they assume they're going to go take a pill and the baby's going to get better. So I think the nuances that you're probably dealing with regularly in the NICU to try to get people to understand when they're not in the heat of the moment dealing with this baby, that they're just devastated by what could potentially happen and that the emotions are in there. We really need to think of it as a community as to define what do we mean by treatment and what are the outcomes that we can reasonably expect by choosing disorders for newborn screening.
And to build on that, these approaches to doing newborn screening, we're kind of looking to the community to help us understand the right thing to do there, right? So the community really has to help develop those guidelines on treatability so that we get some consensus on what that takes. And so that's not something that we can do in a vacuum. We really have to, these are hard questions, I think, and ethicists I talk to have widely varying perspectives on this. And so I think it's really important to get to some consensus to move forward. And I think you started that conversation, I think is a good one to have.
And Wendy, do you have comments on that?
I'll just say the one other point that I would make is that this is within the whole public health ecosystem and within a society. And so the one thing I look towards is this is not just diagnose and adios. You have to be able to have that entire health system that can then absorb what the treatment and support for that child is afterwards. And if you're not willing to commit to that, then you shouldn't be making these diagnoses as part of newborn screening.
Okay, thank you. So I think we have a question from the internet first, or?
Seth Shelnut from TileDB here. I've got a question about the age of onset and treatability when it comes to the paternal lineage, because in prenatal screening of cell-free DNA, it can happen from time to time that you can detect conditions in the parent, in the mother, and that can lead to entire different conversations than people are expecting in the cell-free DNA age. But with newborn sequencing, it's possible to detect inherited conditions that might not have had symptomatic onset in a parent. Is there thoughts about what that sequencing, what the procedures would look like for treating diseases that might not have had onset yet, but you have detected that there is lineage there?
I'll answer that. I love that question. So, and I'll just tell a little story about a baby that I got from the New York Newborn Screening Program many years ago with carnitine deficiency. And we confirmed, yes, the baby definitely has carnitine deficiency. But I started chatting with the mom who was a radiologist. And it turns out she also had carnitine deficiency. But she told me that she never had any idea she had this. But she chose to be a radiologist. She had actually wanted to be a surgeon, but she realized that she was too fatigued and she didn't have the energy to stand and go through all the long hours of surgery. So she was, pre-symptomatic, probably in her 20s. So we started treating mom and we started treating baby, but that's a benign kind of treatment. So that's in a way, it's an easy question. That's just giving the equivalent of a vitamin. What do you do when there's something other that might require a more invasive therapy? And you think that the variants that are in this family probably predisposed to a later onset, adult onset kind of phenotype. And that is a whole different can of worms here. I think the ethical issues are massive, and I think we'll start to talk about them a little bit tomorrow. The medical issues are also kind of complex. Do you want to expose a child to treatment that they might not need? Do you want to medicalize an otherwise healthy child? On the other hand, do you want to undertreat a child who might benefit from it in the long term? So there's no easy answer to that, but it's a fascinating question that we're going to be dealing with.
I'll just add a little bit more data. So we've actually done this because we've completed a pilot study for Duchenne muscular dystrophy in terms of that's a CPK test, but it follows by reflexive then molecular sequencing. And then of course, because it's an X-linked condition, being able to offer the mother's testing. And so we have identified females, mothers, and in some cases, other family members on the mother's side of the family. Of course, women manifest differently, but this becomes the whole story. And because there are later onset manifestations, I wouldn't say that people are shocked about this. I think they're grateful to know for themselves, and again, because of the recurrence risk and reproductive options. But I think it's something that obviously every family can choose themselves what they choose to do, but we haven't seen any terrible consequences, at least in that one example.
Question up there.
Yeah, thank you. So talking about widespread adoption of newborn sequencing for disease screening, right? One thing that's stopping broad adoption is the question of who's going to pay for it. So a comment, a question, and a challenge for the community and the groups that are being represented today and tomorrow. Are you talking with the healthcare payers? Are you talking with the national level payers who are going to be actually bearing the brunt of the cost here? Because this thing has to move out of research funding. It has to move out of philanthropic funding and be truly being somebody paying for this.
Anybody want to comment? I was going to go ahead.
So at this point, and I think this is an interesting question about who is the payer going to be, and at this point, if it were part of newborn screening, I'm not saying that's necessarily where it would be. Each state is done differently in terms of who that payer is, and so that's one question. Or is it in a different system in different countries? And again, different communities will have different solutions to that. I think part of what many of us are banking on, or at least I will say I myself am, is that everything we've heard in terms of scalability, so the cost of sequencing coming down, the cost of analysis, the cost of storage, all of those things being able to come down in terms of cost to the scalability so that it becomes, I'm not going to venture exactly what the price tag is going to be, but something that's not really ridiculous.
I would add that a critical component of all this is cost effectiveness studies. There's been a real great advancement in the rapid whole genome sequencing in the NICU and PICU, and that's been driven by a critical cost effectiveness study that showed that it made sense for the systems to move forward. And so the studies that we're doing now, this has to be part of what we're doing to show the communities that this is something that's worth investing in.
Yeah, I guess I could just comment too, when we talk about cost, we ought to think about the cost of not treating people. And in the past year, there was 2 sort of rigorous studies that were trying to estimate the cost of rare diseases, something that's surprisingly difficult because, as some of you know, many rare diseases don't have ICD codes, and that makes it difficult to determine cost. But there were 2 studies that were done, one by some of my NCATS colleagues and one by the Every Life Foundation, and they both came to the number that rare diseases are costing our medical system about $400 billion a year. So whenever you think about, you're going to talk about the cost of doing newborn sequencing, it's not, compared to nothing. You got to think about the implications of not doing it and the cost of not treating these people. And to say nothing, of course, of the human impact of having these horrible diseases, but also the economic consequences.
Follow-up to that is it's not just the cost, it's also the access. And in a way, getting access to medication is sometimes easier than getting access to things like therapy. Depending on where you live, where the baby's born, they might not have access to basic early intervention or not enough of it, maybe weekly somewhere, 3 times a week somewhere else. So I think if we're going to be screening for disorders where the treatment is early enrollment in programs like that, I think that as part of the implementation of that, we need to ensure that there is availability of therapists who speak multiple languages, depending on the patients that they serve, that it's guaranteed that they can get what they would need.
Just to add into that too, though, the cost associated with not having that diagnosis includes bouncing that patient around to multiple specialists, giving them unnecessary screenings and tests that are not going to be diagnostic for the disorder they have. If you can really pin down what you're supposed to be looking for, you can really save a lot of money in addition to really advancing the patient's management much more quickly and effectively.
Thanks. Did you have another comment, Tom? Or
Not really, but I do know this will be discussed tomorrow as well. So
good. Okay. I think we're basically at time, unless. Oh, one quick question up here. Sure.
So I guess this kind of jumps off the point where we have ended. I'm especially interested in like equity and diverse groups getting access to this treatment and care, especially jumping off the last point of like who is going to pay for this. So I guess I'm curious about, given that each state already has differences in how many diseases that it screens for, and given historical differences in access to healthcare, are we expecting to see, even if newborn sequencing did become widespread, it kind of reinforce already these existing disparities in healthcare, and in some cases maybe worsening them, where there was a case in New Jersey in which police actually accessed a newborn screening sample to isolate DNA to charge the parent in a crime. And just considering already the over-policing of communities of color is creating this huge genetic database, only going to make things worse for those communities and not necessarily lead to better treatment for them.
Anybody want to? I guess my thought is I sincerely hope not, but I do take your point. I think it's a very important one, but I don't know if anybody else wants to comment.
I'll simply say we need to keep this top of mind. And the equity comes from a number of different directions. The first, of course, is that the sequence databases that we have are very European biased. And we're working very hard to make sure that we can sort of help eliminate that bias so that we get the same standard of value and care for all the ethnicities that are going through it. And this is one of the reasons why sharing information across the databases is so important, because we need to make sure that we have enough representatives in order to do that. That's number one. Number two, I think we have a real opportunity to improve equity, because as a very broadly available system, folks in different regions of the country get very different diagnostic care. And this is a potential opportunity to really improve that. But in order to make it really happen, we're going to have to keep it front and center in the development of these different efforts. And that's something that we really just need to do.
So this goes back to one of my other points where I don't know where this is going to sit, but I would ultimately advocate for this to sit within newborn screening and the infrastructure for that, specifically because of the equity issue. To me, this is the one time in life where there is the opportunity to be completely equitable, at least in terms of getting the diagnosis, but that's not where it ends. So it is not diagnose and adios. I was aghast in the early days of SMA newborn screening. There was one state that shall not be named that actually had the screening in place, but did not have the treatments in place. And so babies born in that state were actually going to surrounding states to be able to get their treatment. And that's a death sentence. And to hand someone a death sentence without the lifeline is just, that's deplorable. I mean, that's not the way we should be doing this. So again, if we're going to commit to doing this, though, we commit to the whole 9 yards in terms of diagnose and treatment as we're doing it. The other thing I'll say is that as I've watched new things that roll out, SMA is the one I've been watching most closely. There's variability in states in terms of how large or small they have, what they have in terms of their public health infrastructure. I do think there's an incredible new opportunity to be able to actually share these resources across state boundaries. We do this a little bit, but we can do this even more because so much of this, as we've been seeing in terms of interpretation, can be done in the cloud. It can be centralized. It can be done in a more democratized way, where I do think we have, even across states, the ability for equity, but we have to build that trust first. And I would actually say that legislatively, I hope that you'll help actually, in terms of being able to protect so that those samples and that information is not used in a way that it should not be used in terms of the criminal justice system or anything else with privacy.
Yeah, I think we have time for like one final comment. Adam?
Yeah, I was just going to say too, the protection of the data is just paramount. I think we learned that in or heard about that in the previous discussion as well. But I think democratizing and getting more representatives from other ethnicities into some of these databases is going to be paramount as well, because learning about the context of these diseases, the variants of unknown significance, and the penetrance of these mutations can be learned a lot from those types of things.
Great. Well, I think on that note, we'll end because we're a little bit over time. Thank all the panelists and the audience members for the questions.